Well, hello, I'm Dr. Wendy Burton and I'm a GP from Morningside in Brisbane, and I'd like to introduce Dr. Treasure Maguire. Treasure, would you please explain who you are and the roles that you have?
Right, well, I work here as the Assistant Director of Pharmacy at the Mater, and in my other life, the other half of the week, I teach an array of different health professionals, pharmacology at Bond University and the University of Queensland.
Okay. Treasure, this segment really is just about the principles, pharmacological principles that pertain to pregnancy and breastfeeding. So in general practice, we have in that privileged position of being able to be looking after women before, during and after their pregnancy, so the whole continuity of care. And there are just obviously issues that arise if we see women opportunistically. We can say to them, you know, are you planning a pregnancy? Have you thought about those sorts of things? So with your pharmacist hat on, what are the issues that you'd really like us to take on board preconception, perhaps spilling a little into first trimester? What are the things we should be just cluing our women up on to make them aware of the perhaps some dangerous issues or some potentially dangerous issues?
Well, I think the most important thing and the important role you can play is in helping women to plan a pregnancy. And that doesn't mean they're going to fall pregnant next week, but it's much easier to put in place strategies pre-pregnancy than try and work backwards and deal and mop up with the potential adverse effects from inadvertent drug exposure. So having that conversation when someone is in reproductive age of what vitamins are they using, so that we've repleted their intracellular folate stores well and truly before they might fall pregnant. What's their diet like? What's their weight like? So that we have a woman that is in the best condition to, one, fall pregnant and deliver a happy and healthy baby. And I guess when it comes to the use of drugs, to recognise that pregnant women do use drugs, and in fact the stats show us that 95% of women across the pregnancy will use 4 or more drugs. So we need to understand probably 3 or 4 key things, and the first of these is understanding or revisiting organogenesis and knowing the difference between the potential for a drug to impact in the pre-implantation, the period of organ formation, week 2 to week 8, post-conception, or week 4 to week 10 on an obstetric calendar, and the fact that after that time frame we can work around the use of most drugs from week 10 on an obstetric calendar through to delivery. So I guess the critical things to remember is in the first 14 days after conceiving, drugs have an all or none effect. And so inadvertent exposure to any lifestyle or therapeutic medicine will result in either failure to implant or implantation normally occurring. And so we can look back in that period and reassure the woman that if she's currently pregnant, whatever she was exposed to wasn't a problem. From week 2 to week 8, the individual organs form, so we can look to see whether the drugs that she's using routinely for whatever comorbidities she has are drugs that are or are not likely to impact on organ formation, because the best time to change drug therapy is before she falls pregnant. And then from week 8 after conceiving, or week 10 on an obstetric calendar, through to parturition, being much more conscious of avoiding vasoconstrictors so that we don't reduce the oxygen and the nutrient intake for baby, and being conscious that as we get closer and closer to delivery, the fetus needs to do more and more of nutrient, toxin, drug, both absorption and elimination. And so it's not surprising as the fetus takes on more of this role but is more naive or immature at doing it, that they take longer to do so. So the gap between the mum and baby in terms of plasma levels starts to progressively increase as we get closer and closer to delivery. So that last phase is a period of potential fetal toxicity from drugs. So if we got that basic organogenesis understanding and we can define clearly where a drug exposure has occurred, we're in a much better position to either reassure or do something about the consequences.
You mentioned specifically folate replenishment. Are there any things like, because there's a wide array of supplements that are available on the market, women may take a multitude of over-the-counter preparations. Are there things that we should be particularly advising her not to take, things that might be better or worse depending upon her comorbidities?
Right. The marketplace tends to meet our expectations when there's, I guess, a dollar to be gained, and so it's not surprising that a number of the vitamin and mineral companies have put together formulations that are they put forward as appropriate to use in the pregnancy setting or planning a pregnancy. And they have trade names like Elevate or Blackmore's Gold. There's a good half a dozen of these on the market. And when you actually look at the formulations, they're not too bad. They're certainly much better than using a general multivitamin because they've taken into consideration in most cases the recommended daily allowances and the fact that these RDAs will increase or need to increase during pregnancy. But when you're looking at a formulation that the patient brings in, because one, you can recommend, but secondly, they'll rock in the door and say, this is what I'm taking, is it okay? And they're probably the three things you need to look at is how much folate and link that with mum's pre-pregnancy history. So if she's a well woman, no risk factors for neural tube defects, she can get away with the 0.5 milligram, 500 micrograms of folate daily. If she's epileptic, taking an anti-folate drug, has a history of chronic anemia, particularly hemolytic anemia, then she'll need the 5 milligrams daily, which none of these supplements will supply.
So she'll need additional.
She'll need additional folate.
And I think the recommendation currently is also for obese women or women with glucose intolerance.
That's right.
That they also take that 5
Yes, because they have problem with storage of intracellular folate, as they do with intracellular glucose.
Right.
So that's the first thing I look at. The second is probably whether there's iron in the preparation or not. And if they're taking this very early in the pregnancy, there is no real need for iron at that stage, because you can work out from how much synthesis of red blood cells for the mother and the baby and the placenta, the total amount of iron you need over the life of the pregnancy. But because iron causes a lot of nausea, you don't actually need that early in first trimester. So again, there can be a small amount, but you don't need large amounts of iron in your pre-pregnancy, early pregnancy formulation, but you will need to introduce iron supplementation in early second trimester.
Does it vary between the different brands? Or is it all much of a much?
Some have no iron, some have small amounts of iron, and some probably have too much iron in them, if you're talking about an early pregnancy formula. And then the third important component would be iodine, and the story's changed there. So 10 years ago we said no iodine supplementation because the fetus's thyroid gland is vulnerable to iodine. But we've lost a lot of the iodine in our food chain. And the iodophores that they used to clean milk vats with have been ceased. And so it's taken us a decade to actually get to a population that's relatively iodine deficient. And so the Royal Australian College of Obstetricians put out a recommendation about 3 years ago that we needed iodine supplementation because the mother needs about double the level of a non-pregnant patient, and so it's around that 100 to 200 microgram daily.
And this would be preconception, during pregnancy, and also while breastfeeding, I understand.
Yes. And that may change again in 3 years' time because they've just last year put iodine in our bread. So we may get back to the point where the population is sufficiently replete in iodine that we won't need to be supplemented any longer. And I guess calcium, bones need calcium, so for most of us, if we've got a normal dairy intake, you don't need additional supplementation, but for people that are on soy formulas or just simply don't eat dairy, that's certainly a real issue. So that's probably the do's. The don'ts are avoid large doses of oil-soluble vitamins, particularly vitamin A, because that can increase the risk of retinopathy in baby, but it goes with across the oil-soluble vitamins, and minimise the mineral intake to the RDA allowances. So if you go online, you can go to the NHMRC website and they will give the recommended daily allowances in both the non-pregnant and the pregnant situation, and you can compare that across the formulations. But generally, Elevate, Blackmore's Gold, these types of formulations are not too bad.
Right, so they're targeted to that
population
rather than to the higher level.
Yes.
Okay. What about herbal products, complementary medicines?
Okay, now that's a minefield. Look, generally I am not against complementary medicines. After all, digoxin is a CAM. You know, we're just simply saying this is derived from a plant rather than out of a test tube. However, our general public tend to think that natural is synonymous with safe. So they're often happy to take a herb where they won't take a prescribed medicine, and hence we can get ourselves into strife. So a lot of our education, particularly for people planning a pregnancy, is that natural is not the same as safe, that these are all drugs. Until we get celery growing out of our elbow, it is not endogenous to us, it's endogenous to the soil. So in the same way, we've got to work out, how does it get into the system? Can it be absorbed? Can it be eliminated? And if it's foreign to us, then it's got the potential to cause side effects. And we need to look at the risk versus benefit. Now in pregnancy, the problem is there's a lot less data on, there may be data that says the drug is effective, but there isn't the data to say that the complementary medicine is safe in that population. So whilst I'm not unhappy if, and there are some agents where there's really good evidence, think of St John's wort and mild to moderate depression, but until we get the EBM to support the use in this population, it comes back to the fact that then mum, if baby has an anomaly, has to be reassured that this exposure did not cause that anomaly, and it puts us all in an invidious situation because it's very difficult to prove or disprove. So if you can avoid the use of unproven remedies in this setting, in pregnancy, then it makes your life a lot easier in the long run.
You sometimes hear of liver tonics and things like that. Does that ring any particular alarm bells, or not really? Who knows?
Well, funnily enough, liver function in pregnancy doesn't change significantly. Renal function does. It dramatically increases in pregnancy, and in fact we often need to increase the dose to compensate for that in a pregnant patient, not just because of increased body weight. But there's a lot of oxygenation enzymes developing in baby through the cytochrome P450 system. So use of liver tonics, which focus on enzyme function in the liver, are probably not smart choices for CAMs.
Right. And in this particularly in the from week 20 to term, when baby is taking on more of that role, the metabolites.
Exactly. Yeah. So and there's no real indication for liver tonics in that setting. There may well be in oncology, in patients that have had hepatitis, etc., but not really in pregnancy.
Raspberry leaf?
Raspberry leaf, actually there is reasonable data in two settings, in the labour setting, and I'm not unhappy with patients if they want to use raspberry leaf tea as part of their preparation for labour, and it's also been trialled to augment breastfeeding. There's much less data in that setting.
And the evidence says that it is safe and effective?
Well, there's evidence that says in late pregnancy it's not harmful. We're not talking about an early pregnancy CAM here. Does it actually improve labour outcomes? Now that's where the efficacy evidence is still relatively poor. So I'd like someone to do a really decent RCT. Patients subjectively get benefit from it, and midwives with a lot of history of exposure to patients on these herbs also subjectively claim that it does help, but that's not an RCT. So I'm not unhappy for people to use it because it's not unsafe. It doesn't significantly cause hyperuterine stimulation in that critical period. So if people want to use it, I'm not unhappy for them to do so.
Okay, and what about the women going along and you're getting their hair coloured or their house sprayed for bugs or whatever? So, what are the issues there?
All right, so again, I mean, if you can avoid these things, how important is your perm or being blonde rather than brunette? But it's not actually the application because after all the hair is dead. It's breathing in the fumes, and we come back to environmental toxins, and people really haven't done good studies in this area. They've looked from an epidemiological viewpoint across professions to see if you're, for example, a hairdresser, which might be more significant, and whether you have a higher anomaly rate, and the data isn't really there to say it's a problem. Pesticide exposure, the same thing applies. These are very fatty compounds, so on the skin for prolonged periods, like if you're removing lice, you'll certainly get systemic levels, but long as the house is sprayed with you not in it and it's given time to settle, then it becomes a topical exposure and relatively small amounts on hands, fingers, etc. So basically lots of reassurance and common sense.
Okay, good.